extension as well. So very rarely you find a knee where only flexion is limited and extension is complete. Very often, even when they had PhD, you will see maybe extension is limited by 5 degrees or 10 degrees if you compare with the other one. So I will show you how I proceed to complete nicely the extension, because what we can see very often is that you are nearly extended but not full extended. So when you are not full extension, you have this 5 degrees, 10 degrees loss of extension, your knee won't be stable. It won't be really stable. Why? Because the muscle organization won't be perfect. Vastus medialis is working on the last 10 degrees of extension. The real coordination for the patella is really up around 0 degrees and +5, really here. If you don't have that, you won't have a real stable knee. Second, the ligaments, the medial collateral ligament really gives stability in extension. As soon you lose it, you see here that extension is not there anymore. When I bring it up, now I cannot move her. So we need full extension to have a good locomotion and to have a good stability in the joints itself. And if you don't have extension, you won't be able to activate vastus medialis properly. And vastus medialis is one of the key muscles in the organization of the muscular stabilization of the knee. So if it is not activating, something important is missing. Therefore,
vastus medialis is key stabilizer of the knee.
It plays a key role in the stabilization of the knee, in extension phase. And if you think, when you walk, I'm bringing my body weight from the left foot to the right. In that moment, when I'm doing that, my knee is an extension. And if I don't have a good stabilization here with vastus medialis and the others, you won't be stable. So vastus medialis is important in the last 10 degrees of extension. It's very important in the organization of stability of the knee. So therefore, if you are blocked, if you don't have full extension, that means neutral position +5 degrees, you won't have a proper stability. If you have no proper stability, you will get soft tissue pain. That means you have problems around the patella, maybe you have a problem behind. You get some soft tissue problem because you don't have proper stabilization. And the ligaments will be overused, overstretched, and you get inflammation. Sometimes you have chronic knee pain, and if you look carefully at it, you don't find really a mechanical problem. There is no significant internal intrinsic lesion, but you are missing stability. So when you do a lot of training to the muscle and you bring up a good stability, then these problems go away. In sportmen, very often the problem is not the tissue itself, it's missing stability in end range extension. And that stability comes by a good mobility and then the muscle control, reactive training, etc. So that we can come to this extension, I want to show you a few techniques. We had yesterday the technique even doing like this. Now I do it the opposite. Now I'm talking on the level of accessory movement, joint play. To have a good extension, the tibia plateau has to come to slipper forward. So before I really extending, I take care that this joint play movement, this gliding from tibia plateau, it's a posterior anterior gliding, that this gliding is sufficient. It has to be a little bit, just a little bit. It is as much as the cruciate ligaments can give way. A little bit of slack I should be able to take off here. So that little bit of movement should be there. I have to go with my hand really completely behind the knees so that I move the tibial plateau symmetrically. If I'm just on the inner part, I will move the inner compartment of the knee. I won't move symmetrically. So I go behind it. I hold the femur condyles, and now I move it towards me. Move it towards me. This is posterior anterior gliding of tibia. I have to organize to create this joint plane movement before I'm going to stretch. And I normally start to do it in this position here. Later, I can go down in this position. Now, before I'm going into the real stretch, I will work a little bit in the popltea. There where the flexion takes place, inside here. I just go in with my fingers like this and I work soft tissue work. Because somebody who was for a long time in flexion will have contracted tissue, ligaments, tendons, muscles, and connective tissue. Don't forget, in the knee we have a lot of connective tissue in the flexion part of the knee. So let's take off this contractures, this adhesion. So I go deep into the knee on the inner side of the adductor muscles, the tendon of semimembranosus, semitendinosus, gracilis longus. I just on the inside of this, and I'm working in this tissue. I make it soft. Then I will work here on pes anserinus, that part where these muscles are coming and attached to the tibia. I just hold her like this.
What is working on pes anserinus? Cross-flexion.
Yeah, look, if you can see, you can look. What I do, I mobilize the tissue. Here I'm not using only transverse flexion. I really mobilize. I grasp the tissue. Now I'm really in it. I take the outer part of these tendons. There are several tendons here. And then I'm pulling it up here. I just mobilize here the attachment. And then I go deep in, even you can feel the tendon, how I move it. You go as close as possible to pes anserinus and move the tissue. Hold it so you get some stretching of the fascia there, the connective tissue, and on the insertion. Mobilize this insertion. And then, as we did already yesterday, you do this soft tissue work. Take the tissue like this, and there is a special technique we use. You pull on the tissue in a way of a spine like this. There is a technique called myosynergetic fascia treatment. It's from a German author, and he works a lot with spastic children, doing like this. He just do these stretches. It's somehow a spiral-shaped stretch of tissue to reduce spasticity. And it's true, it's very effective. I'm stretching this fascia here inside. And you do it the opposite way too. You can feel the stretch. Now this hand is going like this, and this hand is going like this. And hold the tissue, stretch it really, and then you can do this. Short strokes like this. Open the tissue here. Be careful when there are varicose veins. There you don't go deep into it, but work on it. Because so often in elderly people with osteoarthrosis at the knee, they're in this position. The problem is not really the articular part, it's the extra articular part. These are the contractions here. So go work them nicely in flexion and bring them into stretch. So before I go to full extension, I really work sufficiently on the soft tissue. It's an old osteopathic rule. Before you mobilize, work on soft tissue. Prepare the soft tissue to be extended, to be stretched. Where you have soft tissue lesions, dysfunction, movement moves in place nicely. So organize the soft tissue before you go to stretch and challenge the articular part of the joint. This is an old osteopathic rule, and everyday clinical practice confirms it. It's like this. Okay. Now we are down here. If you have done enough joint play, it's the time to do a longitudinal stretch. I hold the joint up here. Now I'm just pulling. I'm not in full extension. In that slight flexion of 10 degrees, and I give a longitudinal mobilization, or if I hold it, it's traction.
People are so big and heavy.
You have to be strong. There are other ways as well to do it, seating position. But if I can take you like this, I do it like this. Or you can do it sitting. You can sit up. I can show you in sitting. If you are small and the patient is very heavy, I just do it like this. Hold it nicely. You sit a bit back. Okay? And now you do it like this. And you can hold it.
It works better than when you feel that way. I feel the effect more when you do it like this.
Then when you're coming more in this position, you do it more like this.
Okay.
Okay.
Left to bed? Now we are coming to mobilize this extension part. When you are coming to neutral position, remember the medial ligament will be much stretched. So prepare it. How do I do that? Again, like this. I'm doing now transverse friction. Work really on that medial ligament. Do a lot of this transverse friction. Prepare the ligament, especially the insertion. When you have some adherences, it's always on the insertion here. So work nicely on that even for 5 minutes. It should not be too painful. Is it okay? Yes.
And then we can be ready to extend, to do pulse extension, mobilization. Gently like this. An advanced technique is that you grasp the joint line, and with one hand I'm just below it, and with the other I'm above it, and now I push it a bit through into the cushion of the bed. This is a combined technique, quite intensive. That you can do if the patient has no artificial joint. In artificial joint you don't do that.
Yes.
But if you have an osteoarthritis patient and so on.
So you say that's a combination of nutrition.
Yeah, this is, it's anterior posterior pressure on the level of the joint line while doing extension. Because when I'm pushing down, I do a little bit extension. But I do as well this pressure. It's somehow a forced extension. When you do only this, you're moving only the tibia towards femur, which is blocked. When you do that, you do something like this. So you get a more stretch on the back.
Okay. Can it be done with maybe a rolled shoulder here, the combined movement?
When you do that, it means you're already
It's like
above zero. Above zero. If you do that, sometimes you put a little book here.
Yes, that's what I'm
Book,
saying.
so it's a little bit more stable.
Yes.
You will, so that means you are doing combined movements in end range position.
position is really the last thing we do. But maybe in a sportsman, he has no problem when you do like this, but when he's walking a lot or running, he has this problem. Sometimes you need combined movements in end range position. It's a very advanced technique, yes. Prepare nicely the tissue before. Yes. So this technique. But it's very advanced. This is the question when end range pain is there, end range problem, you will work on that. Okay. Stop.